strangulated hernia. Okay, before going into strangulated hernia, let us discuss what are all the various complications in case of a hernia, right? Even before that, I want to tell you a few things. Let us assume that this is the muscle wall, okay, through which the hernia is coming out. So here there is a herniation. This is your hernia, sac of the hernia, right, which consists of neck, body, fundus, various parts which we need not know now, right? This is your hernial sac. Within the hernial sac, you are going to have the contents. Let us take the intestines, or whatever you want you can take. There are intestinal loops which are present within the hernial sac, right? Now we will look at the complications of a case of a hernia. First one I want to tell you is irreducible. So what is this term? So what do you mean by this word irreducible? So the first one I want to tell you is irreducibility of the hernia. Irreducibility, why this irreducibility occurs means the hernia is not reducing, right? Why this irreducibility occurs? It occurs due to adhesions. Okay, now the question is, sir, adhesions between what? Adhesions may be between the sac and the contents, or between the contents, whatever it is. Due to adhesions between maybe of the omentum, sac and the contents. Anywhere between them, if there are adhesions, what it will lead to? Irreducibility, right? Now coming to the second complication is obstructed. When you are going to call it as a case of obstructed hernia, obstructed means there is already the hernia is irreducible, plus there is obstruction to the lumen of the gut. So when I am going to call the obstruction to the lumen of the gut, let us look at in the diagram. So the moment I use the word adhesions means nothing but the adhesions between the sac and the contents. It will lead to irreducibility. Then what is the meaning of obstructed hernia? Obstruction means, if I take this is the bowel, inside the lumen of the bowel there is, within the lumen if you see, so within the lumen itself, if you are going to get some obstruction, then I am going to call it as a case of obstructed hernia. Irreducibility is due to adhesions, maybe between the sac or the omentum or the contents, whatever it is. But whereas obstruction is due to the obstruction of the lumen of the gut, that is when I am going to call it as an obstructive hernia, right? Now coming to the next entity. Next entity is incarcerated hernia. Incarcerated hernia. This is obstructive hernia. Then next coming to incarcerated hernia. Incarcerated hernia is nothing but a obstructed hernia only. Obstructive hernia only, but the obstruction is caused by fecal matter. This is when I am going to call it as a incarcerated hernia. Let us look at in the diagram. So if there is obstruction to the lumen of the gut, then I am calling it as obstructive hernia. But when to call it as a incarcerated hernia, if you ask me, if the lumen is blocked due to fecal matter, then I am going to call it as an incarcerated hernia. Incarcerated hernia is nothing but a type of obstructive hernia wherein which the obstruction is due to the fecal matter. Now coming to the next entity. We have seen the irreducible, obstructed and incarcerated hernias. Now coming to the our actual question, that is strangulated hernia. This is our actual question now. Now in strangulated hernia means there is already irreducibility, there is already obstruction. On top of these two things, if you also get a vascular compromise as well, then I am going to call it as a case of strangulated hernia. Right? Sir, can you please elaborate the vascular compromise? Yes, we will do that. Whenever there is a vascular compromise, what is going to happen? The first thing which happens is venous return is something which is going to be occluded initially. Even before artery, it is the venous return which is going to be impaired. So due to that, what will happen? When the venous return is impaired, what happens? Due to that blood collection, it will lead to congestion. It will lead to mucosal ulceration. Okay. It can even cause a hemorrhage also. So within the gut wall, what you can see means, you can see the congestion of the gut wall, you can see the mucosal ulceration of the gut wall, and you can see hemorrhages here and there. Now, if at all the obstruction is relieved at this point of time, then it's okay. But even still, the obstruction if not relieved, if obstruction is not relieved at this point, what happens? This will continue happen, and what happens at some point of time, what is going to happen is there is constriction of artery as well. Initially there will be venous obstruction. Now even the artery is going to get obstructed. Whenever there is constriction of the artery, you all know, whenever there is constriction of the artery, that part which is supplied by the artery is going to undergo gangrenous change. Now, after gangrene, what is going to happen? Gangrene, where it is going to occur at the first? Gangrene is going to appear first at the ring of constriction. Okay. Now, due to gangrene, what happens? Because there will be gram-negative bacteria which are going to proliferate here. Gram-negative bacteria are the ones which come and proliferate here. Due to that, there will be certain complications. One is septic shock. You can call it as a endotoxic shock. And the other likely complication is peritonitis can also occur. Right? First of all, there will be venous congestion. If the venous congestion, in the venous congestion phase, what happens? The gut wall is going to show you mucosal ulceration. It is going to show you congestion, and it may have some hemorrhages also. If obstruction is not relieved, it is or even artery is going to be constricted, there will be gangrene. So after that, what happens? There will be gram-negative bacteria which are going to proliferate here, and there is even a likely complication of septic shock, that is endotoxic shock, and there is even a complication of peritonitis as well. Now coming to the clinical features with which the patient of a strangulated hernia is going to present to you. You obviously know it is a case of, irreducibility, that's okay, but it is a case of obstruction only. Along with that, there is vascular compromise also. Now, what is the clinical feature? Without any doubt, pain. Pain is part and parcel of any obstruction for that matter. Always pain is part and parcel. So, how the pain will be? It is a sudden pain, and it is going to be a severe pain. Okay. If the patient has gone into endotoxic shock, you can even see the features of shock also. Okay. Now, what are all the examination findings you can see? On examination, what you can see? Tense, tender, On local examination, the swelling is going to be tense and it is going to be tender. And one more thing, there is no cough impulse. I have already told you, strangulated means it is already irreducible. You cannot find any cough impulse also. And it is a irreducible swelling. And one more thing is, recent increase in size of the swelling is also seen. Okay, these are all the features. The swelling is going to be tense, it is going to be tender, and the irreducibility is already there, and the swelling is going to be increase in the size. Now, coming to the management of a case of a strangulated hernia. One first thing I want to do is I have to make the patient in a foot has to be elevated position. Why I have to make the foot elevated? Because due to gravity, what may happen is the hernia may go back into the inguinal canal. Okay, that is why I have to make the foot end elevated. That is the first point. The hernia may become reducible also. Foot end elevated. Why? This irreducible hernia may even reduce if you elevate the foot. Now, already there is obstruction. Maybe there may be gangrene also. All these things, if you take into consideration, any obstruction also, you have to give IV fluids to the patient. You have to give analgesics to the patient. Okay. And one more thing I want to tell you here is, you have to make the patient, you ask the patient to flex his thigh, and ask him to adduct medially. Okay, to adduct and to medially rotate also. Right, what are all the things you have to do? You have to do flexion, you have to do adduction, and you have to do medial rotation of the thigh. You have to do. Write it down. Ask the patient, thigh in a flexed position, adducted position, and a medial rotation also has to be done. Right, this has to be done. Now, there is a word called as taxis. In strangulated hernia, there is a word called as taxis. What do you mean by the word taxis? Suppose I will draw here with suppose this is the swelling. Okay, let me. Yes. So what I have to do in taxis is, on one side with my right hand, what I am going to do, I am going to try to push the swelling. I mean, try to squeeze the swelling on one side. And with my left hand, what I have to do is, with my left hand, I will try to reduce the swelling into the inguinal canal. Okay, with the right hand, I am going to squeeze, and with the left hand, I try to guide the swelling into the inguinal canal. This is what is called as taxis. So with my right hand, I am going to squeeze here, and with my left hand, what I am going to do is, I am guiding this swelling to go into the inguinal canal. This is what is called as taxis. Write it down. With my right hand, what I am going to do is, sac is going to be gently squeezed. So what I am doing with my left hand, the proximal portion of sac is guided into the inguinal canal. Right? This is what is going to happen in taxis. Now, can anybody tell me the contraindication of taxis? Can anybody tell me the contraindication of taxis? Yes, I have to taxis is contraindicated in presence of gangrene. Suppose there is a gangrene which has already came here. Here there is some gangrene. If at all there is gangrene and I am going to do taxes, what happens? The infectious material which is there is going to spread throughout. That is why taxis is contraindicated if there is a gangrene, right? Now, moving ahead. Right. Now coming to surgery for strangulation. Nothing more specific I want to tell you. Just I have to give a incision in the inguinal region only. Inguinal incision I am going to give. And the next step is I have to identify the sac. I am going to give the incision. I have to identify the sac. And after that I have to aspirate the fluid which is present in the sac. Aspirate the toxic fluid which is there. Now, the first thing I want to do is I have to divide the constricting segment, okay? I have to divide the constricting part. Now, I have to check for the viability inside there, okay? If by chance anything gangrenous, if I found out, always any gangrene, you should always do resection of the gangrenous part has to be done. If it is viable, that's fine. But if I see any part which is gangrenous, I have to remove out the gangrenous part, resection of the gangrenous part. After that, I have to get the repair of the hernia done. I have to get the repair of the hernia. Take home message. Should I use any mesh here? No, I should not place a mesh in case of a strangulated hernia. Repair of hernia has to be done, but without a mesh I have to do. Okay, if I put a mesh over there, by chance if there is any infection which is left over in that part, the infection can easily spread. Okay, mesh is never used in case of a strangulated hernia. Moving ahead, after all this I have to start broad spectrum antibiotics also I have to start. Okay, in a nutshell, if you ask me what is strangulated hernia, strangulation which we have already seen, it is already there is irreducibility, already there is obstruction, plus on top of that we are going to get a vascular compromise. So elaborating the term, I mean, in which hernias we can see this strangulation? We can see in femoral hernia. I have already told you in femoral hernia the maximum risk of strangulation is seen in femoral hernia. Even in inguinal hernias, indirect hernia, you can see strangulation. Now coming to the vascular compromise part of the strangulation, there is arterial, initially there is venous compromise. What happens to the gut wall? There will be congestion, there will be mucosal ulceration, and there will be hemorrhages also. If obstruction is not relieved, what is going to happen? There will be constriction of arteries as well, which may lead to gangrene. If the gangrene sets in, what happens? Gram-negative bacteria are going to proliferate. Ultimately, there might be a complication of endotoxic shock and peritonitis as well. Now coming to the clinical features with which strangulation is going to present. Strangulation is also an obstruction. On top of that, there is vascular compromise also. So pain is part and parcel of this condition. Pain is very severe. Pain is sudden in onset. And when you examine the swelling, you can see tense and tender swelling you can see. And sudden increase in the size of the swelling is also given by the patient. Now, how to manage a case of strangulation if you ask me? As usual, any obstruction for that matter, and in the first thing I have to do is elevation of the foot so that the irreducible hernia which is there, which may itself get reduced. And I have to give obstruction as usual, IV fluids, analgesics I have to give. Right. And then what I have to do? I have to go for the surgery. So how to do surgery? Just go and incise in the inguinal region and you have to check for the, you have to divide the identify the sac. Okay, and then what you are going to do is divide the constricting part, check whether it is viable or not. If it is already gangrenous, you have to do resection. After that, what to do? You have to do repair of the hernia. Take home message: without a mesh. Right. After that, as usual, you have to give broad spectrum antibiotics to the case. This is how strangulation hernia goes on. Okay. Now coming to ranula. Now coming to the ranula. Ranula, if you ask me, ranula is a, first write it down, cystic swelling. So what is the cause? It is a sublingual salivary gland problem, or maybe in the accessory salivary gland also. Okay. And one more thing is, suppose this is the tongue in a reverse way I have drawn. Okay, in the floor of the mouth, ranula is seen in the floor of the mouth. Okay, in general one side of the midline. No, I cannot say midline, but one side of the midline I can say. Right. Why it is forming? Due to obstruction to the ducts. Due to obstruction to the ducts. Okay, it is forming. That is why I am calling it as a retention cyst. Is ranula retention cyst or extravasation cyst? It is a retention cyst. Why? Because it is occurring due to the obstruction of the ducts. That is why I am calling ranula as a retention cyst. Okay, we have already drawn the diagram. Right. Clinical features. What is the age group in which we are going to see? We can see them in young children and adults. Young children and adults, we can see the ranula. Now, what is the site? Site, I have already told you, floor of the mouth. Floor of the mouth is the site where I am going to find the ranula. Now, ranula, if you observe, it is a cystic swelling. It is a cystic swelling. Obviously, you know, any fluid or content, then it will be cystic in nature, and it is a fluctuant swelling. Very, very important. It is transilluminant. I accept, but please write it as brilliantly transilluminant. Brilliantly transilluminant. Now, it is going to be bluish in color. Now you may get a doubt, sir, why it is bluish in color? Because of the mucosal layer, outer mucosal layer, it may appear bluish in color. Now coming to a particular type of ranula, that is called as plunging ranula. Sir, what is this plunging ranula? Plunging, in simple terms, if I want to tell you, here there is ranula. Okay, here there is ranula. Now this ranula is going to spread, and what happens is, even it is going to pierce one muscle. What is that? Can you name the muscle? Can anyone guess? Yes, this is your mylohyoid muscle, and it is going to pass through this ranula, which has to be present in the floor of the mouth, passes through the mylohyoid, and it is going to present as a swelling in the submandibular region also. So what is plunging ranula? It is a dumbbell shaped swelling, where one end of the swelling is present in the floor of the mouth, and the tract is passing through the mylohyoid muscle, and the other end of the dumbbell has to be in the submandibular region. This is what you are going to call it as a plunging ranula. If I take a ranula over here, In plunging ranula, if I take this ranula, due to which it is formed? It is due to duct obstruction, which is causing you retention. That is why I am calling it as a retention cyst. But how this part is formed is, if you ask me, it is due to extravasation. Means, if you ask me plunging ranula, it is not only a retention cyst, it is an extravasation cyst as well. Right? There is swelling, I accept, but not only in the floor of mouth, there is swelling in the submandibular region also. This is how to differentiate between the ranula and the plunging ranula. Now, coming to the treatment is most interesting for me. Why? Because even though this is a cyst, first one, I want to tell you a few things. Incision and drainage is not done. Everybody knows this incision, why we will do. Most of you want to answer it as marsupialization. But I would like to correct you. Even marsupialization is not the correct answer now. As of now, what we are doing is excision through transoral route. This is what you have to answer. Please write marsupialization also and keep a wrong mark there. Now marsupialization is not done. Rather we are doing excision, right? Excision of the ranula we are going to perform through the transoral route. This is how we have to treat a case of ranula. So in simple terms, if I want to tell you what is a ranula, ranula is nothing but a cystic swelling which is present in the floor of the mouth. So usually on the one side of the midline you are going to see the swelling. Okay, and clinically how it is going to present? Swelling in the floor of the mouth. On examination, what you can see? It is cystic, it is fluctuant, and it is transilluminant also. These are the features of a ranula. There is bluish discoloration of the ranula because of the mucosal covering. And coming to how to treat a case of ranula, it is not incision and drainage, it is not marsupialization. You have to do excision of the ranula through the transoral route. Coming to the next question, that is necrotizing fasciitis. Necrotizing fasciitis, if you ask me, it is nothing but an infection of the skin and also of the soft tissues. So necrotizing fasciitis is nothing but an infection of the skin and the soft tissues, including the deep fascia. Okay. Now, what is the common site of necrotizing fasciitis? You already know. It is the lower limb. You are going to see this site being the lower extremities. Now, what is the causative agent for necrotizing fasciitis? Before knowing the causative agent, I am going to divide this into type 1 necrotizing fasciitis and type 2 necrotizing fasciitis. There are two types of necrotizing fasciitis, type 1 and type 2. The cause of type 1 is polymicrobial, mixture of organisms are going to cause. Whereas in type 2, it is due to group A beta hemolytic strep. Write it down. In type 1, it is polymicrobial. Whereas in type 2, it is due to group A beta hemolytic strep. Right, such as Streptococcus pyogenes. Now, what are all the risk factors for the development of this necrotizing fasciitis? Any person in whom the immune system is going to be lowered, the ability of the immune system is lowered, means any diabetes mellitus case is there, or any patient who is on steroids, or any patient there is immunodeficiency like in AIDS or any other immunodeficiency disorders patient, or if there is a malnutrition patient is there. These are all the individuals who are at risk of developing this necrotizing fasciitis. So clinically how the patient is going to present to you is very important. I have already told you it is a problem mostly in the lower limb. So what are all the things I can see here? So obviously pain will be there. Okay, and even there will be gross swelling of the limb I can see. So gross swelling I can see of the limb. And now coming to the what are all the things I can see in this case means it will be red, it will be edematous, and I can see even areas of necrosis I can see, and even I can see the areas of ulceration also. So areas of ulceration I can see, redness I can see, edematous will be there, all these things you know. Even I can see the areas of necrosis also. Now, how to diagnose this case? Diagnosis is done by a biopsy. Now, how to treat this case? How to treat this case? One thing is it is due to bacteria. I have to give antibiotics to the patient. And I have to do surgery. Why? Because there is involvement of all the skin and the soft tissues involvement. Muscle is not involved basically, but skin and soft tissues including the deep fascia is involved. So I have to get the debridement. I have to debride that. In the future, I can get a skin grafting done after. But now, what is the treatment? If you ask me, I have to do debridement. Okay. So, in a nutshell, if you want to discuss necrotizing fasciitis, the first thing is it is an infection of the skin and the soft tissues. Muscle is generally not involved. Deep fascia is also involved. Now, what is the site of the infection? Usually in the lower extremities. So what is the causative agent? Type 1 and type 2. Type 1 is polymicrobial, whereas type 2 is due to group A beta hemolytic streptococci. Coming to the clinical features, pain is obviously there. There might be gross swelling of the limb also you can see. But most important features are there is redness, very important. There is ulceration, very important. There is necrosis, very important. Redness, ulceration, necrosis, these are the, and edema is also there. These are all the important points when you are going to inspect the case. Now, coming to diagnosis, how to diagnose means biopsy has to be taken. How to treat the case if you ask me? Infection, so antibiotics definitely. And surgery, what to do? There is ulceration and even there is necrosis also, so I have to go for debridement, and at a later date I can get a skin grafting done. Okay, this is necrotizing fasciitis in total. Thank you for watching.